Hello to everybody and welcome. I'm Professor Jackie Curtis. I'm the Executive Director of the Mindgardens Neuroscience Network. I'm a psychiatrist and I've worked for many decades in clinical and translational research, and my work has been predominantly in early psychosis and youth mental health, and focusing on the improving the lives of people with serious mental illness in terms of their physical health. I'm really pleased to be here to chair today's session, and this is the last of our webinars for 2025. Before I move further, I'd like to just acknowledge the strength and the resilience of Aboriginal and Torres Strait Islander people, who are the traditional custodians of the diverse countries from which we are joining this meeting. And I do know it's quite diverse. I can see US dialing in, as well as other states as well from Australia, which is great. I'm privileged to be calling from the land of the Bidjigal people of the Eora Nation, and I pay my respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Island peoples present today. I'd also like to acknowledge people with lived and living experience of mental ill health and recovery, and the experience of people who have been carers, families or supporters. I'd like to welcome you to the Mindgardens Psychosis Webinar Series. It's a central part of the Mindgardens Tertiary Referral Service for Psychosis, the TRSP. The TRSP is a statewide service funded by New South Wales Health and hosted by South Eastern Sydney Local Health District. We're very grateful to South Eastern Sydney Local Health District and New South Wales Health for their ongoing support of the TRSP. So that would be a general introduction we have for all the other webinars. But what we are very much looking forward today is to have an in-depth look at the TRSP itself, and to introduce you all to our new clinical director, Associate Professor Brooke Short. So we are going to be hearing from Brooke around the topic of today's webinar, hearing more detail about TRSP in terms of its clinical services, but just noting that TRSP also runs education and training programs to build capacity in caring for people living with complex psychosis. And this webinar is an example of that capacity building that we support in Mindgardens. We have these webinars monthly, as many of you know, and this is our last one for this year, but we've got already a lineup of speakers for next year, so we'll let you know about that a little bit later. So a bit of housekeeping for the beginning before I get to Brooke, and that is that you're going to be seeing, if not already, some poll questions coming up. Here they are during my introduction, and there'll be a couple more at the end, and we'd really appreciate you answering. Your answers are anonymous and help us constantly improve our webinars. There will be a Q&A session at the end, so please add any questions into the Q&A window rather than in the chat box, please. And we will endeavour to answer as many as possible. We also appreciate any feedback in the chat or by email. So if your question isn't answered and you'd like to share any suggestions for the future, we'll be putting our contact email address in the chat box. We're going to be recording this and distributing it to those who've attended, registered sort of attendees within 2 weeks. I might note that there are over 300 people who registered for today's seminar, which is fantastic. So it's finally, it's my great pleasure to introduce our guest speaker, but also our leader of the TRSP for today, Associate Professor Brooke Short. Brooke's a Senior Staff Specialist Psychiatrist at Prince of Wales Hospital and is Adjunct Associate Professor at the University of Notre Dame, and also affiliated with UNSW. We're fortunate that Brooke has been appointed to this role. We're very thrilled at this, and Brooke's been permanently appointed into this role. So we're very much fortunate to have that leadership. Brooke's career has been shaped by a commitment to improving outcomes for individuals living with severe and complex mental illness, particularly schizophrenia and mood disorders, and that you've had academic appointments, apart from the two I've mentioned, across other major Australian universities. And Brooke's research is focused on the intersection of severe mental illness, comorbidity and health service reform. Brooke's also led and contributed to several influential studies, including a world-first systematic review of ketamine safety in depression and the role of artificial intelligence in diagnostics and service delivery, amongst others. Brooke's also had a history of working with the WHO in the past and brings a lot of wealth from system reforms, systems of governance and government, as well as clinical and research. So we're very lucky to have you. Please join me in welcoming Brooke to present Beyond Referral, Transforming Tertiary Psychosis Care. Thanks, Brooke.
Thank you, Jackie. I just wanted to double check. Can everyone hear me? Yes, good, thumbs up. Thank you, Jackie, for that very lovely and generous introduction. And thank you to everyone here in the audience, some of which I can see and recognise familiar faces. And also we have some of our TRSP team members also joining us. I also wanted to say, just before we start, a big thank you to Andrew Watkins, also affectionately known as Andy, who has been chairing these webinars for pretty much the majority of this year and has done a brilliant job. So hats off to Andy. And similarly to Jackie, I wanted to also pay my tributes to anyone here from Aboriginal Torres Strait Islander backgrounds, anyone living with mental illness or recovering from mental illness, or who cares for people with mental illness. So as Jackie pointed out, I'll just move with the slides, if they will work. Oh, they might have frozen. Here we go. That's moved on.
Yes, it has.
Oh, good. So let's get into it. So as Jackie pointed out, today's webinar is about TRSP, and my main aim today is to give you an understanding of where TRSP has come from and what we're looking forward to in the road ahead. And so we'll cover the background context, of which some of you may know and some of you might not. So this could be enlightening, and it's important to understand historically how TRSP was set up. Also, the services achievements thus far, which some of you would know, TRSP has been in place for a little over 4 years, as well as our new model of care, which now includes more service offerings, and to let you know about our new referral pathways, which will be now digital come next year, which we hope will lessen the burden on clinicians sending in referrals. And finally, future directions, as well as I would like to take as many questions as possible and any reflections and feedback, especially if you have referred to TRSP the last 4 years. So some of these future directions are already in the workings, and some are what we are hoping for. So TRSP actually started as a Commonwealth-funded pilot project, which began in 2020 and led by our wonderful Professor Julia Lappin, as well as Robin Ellis. And the main aim was to address the major gaps for people with schizophrenia, in particular treatment-resistant and complex psychotic disorders. And essentially, over those 4 years, it has demonstrated the value of a centralised, specialised service for diagnostic uncertainty, treatment-resistant risk and comorbidities. And it's the only service of its kind in Australia. There are services similar in the UK, Canada, and the USA. However, we are pioneering this kind of service nationwide. It now continues on as of this year with New South Wales Health funding, and that funding has been secured for the next 4 years. And I guess the aim is that TRSP works in partnership with adult community, both community and inpatient services, so that the teams, appreciating the complexity and chronicity of these conditions, and just try to support you as clinicians of these consumers working together. At the moment, we work in what's called a consult liaison model, which means that we do provide care. However, the team still carries ownership of the consumer, but there are ongoing discussions regarding future plans, which might include an inpatient stream, and which we can talk about later in this webinar. So we pride ourselves on having a team approach, of which I think everything can only be achieved in great form with teams and collaboration. And so that's a team both within our MDT, multidisciplinary team, as well as your multidisciplinary team. And in terms of the makeup, I'll just jump a slide. In terms of the makeup of our team, we are comprised of staff specialists, registrars, social worker, OT, admin officer, and our operations manager. We also have a research officer 2 days, and a neuropsychologist. And I think it's important to point out that all of these team members are part-time, including myself. And so we're not a full-time funded team, but we do, I think, provide large impact despite the part-time nature. And just back, sorry, one slide, is to talk about how we operate in partnership. So we value our stakeholders, of which we have Mindgardens, who are one of the predominant stakeholders, of Jackie here representing Mindgardens today, as well as obviously the LHD, Southeast Sydney, who help provide us with essentially housing, so rooms, which is very important, as well as governance and support. And our other large partner is obviously New South Wales Health, who are funding us at the moment. So I wanted to cover what in the last 4 years we've seen in terms of referrer overview and consumer characteristics. And we'll start with referrals across the state, sorry. So we are aimed at trying to provide more support for more of our regional rural folk who may not have the ability to gain second opinions or have other experts involved, who might not even have the ability to call on a neuropsychologist or other allied health team members. However, we do still take metropolitan LHD referrals as well. And here you can see this is covering the last 4 years, essentially the referral rates. And in orange is our regional rural, of which we saw some interesting spikes in referrals. And then in blue is our metro. And so the aim is to try to increase this, to scale up in the next 4 years and increase our reach. In terms of where the referrals came from for where the consumer was, you can see that the majority came from those from community mental health services, which is wonderful. So the patient didn't have to wait to get into an inpatient setting. However, near equal was inpatient setting. And we follow the journey of the consumer. So sometimes the referral came when the patient was in the community or vice versa inpatient, but they might have then tracked to back discharged or to rehab, or so we follow all across the state. Some of our consumers live in, say, the Campbelltown area, but have been referred and accepted to Bloomfield, and we follow through with that referral the whole way. We do ask that the home team try to stay involved, though, given the patient will likely go back, and that will be able to help us ensure that some of the diagnostic and management suggestions can be followed through. But this is essentially in line with what we expected, that there would probably be equal rates of referral from regional, remote, inpatient community, less so from like forensic settings and less so from rehab settings. And then the reasons referred, we actually listed this on the referral. If any of you have referred, there was a long list of which you could tick boxes. That will no longer be the case in the new referral, but it is very helpful information for us nevertheless. But we'll probably gain it through other avenues instead of having to box tick at the start. But the majority was understandably high illness burden. And second to that was long duration of illness burden. But I just want to point out that in particular, since I've been on, in this role in May, it's been interesting that we're getting a lot of referrals even from early psychosis teams. And so the idea is that you don't need to wait until it might have become, long and enduring high illness burden. If you would like some input earlier on, we encourage you to refer. And this pie chart just displays predominantly the primary diagnostics that were identified through the assessment with TRSP. So you can see in the pie chart with the orange that the majority did have either established prior or through the TRSP assessment a diagnosis of schizophrenia. And then behind that was schizoaffective disorder. But there's also around 10%, so 1 in 10 of referrals that come through, of which the diagnosis may have been an enduring psychotic illness, and then there's a rethought of that, or other, so essentially other illnesses. So if you're unsure, you're not sure it could be an enduring psychotic illness or even psychosis, we encourage you to refer to us, because we can, with our expert team, try to help navigate, sometimes some tricky diagnostics. The other thing is that the mean age was around 40 years, which is interesting. And as I said before, there's no harm in referring earlier than that. That the majority of the people referred were male, that many were born in Australia, but that there was a high percentage of people identifying as Aboriginal and or Torres Strait Islander. And we do know that people with this cultural background can have higher risks of complex mental health disorders, as well as the median age of illness onset, as expected, was around 20 years, which is what we would expect with an enduring psychotic illness like schizophrenia or schizoaffective disorder. But you can see that the interquartile range in brackets there was quite broad. And a lot of that I take as inference that there was probably some illnesses that were more bipolar, and that sometimes is diagnosed a bit later. And then the median illness duration at the time of the TRSP referral was that our consumers had been living with these experiences and symptoms for about 17 years, but you can see also the interquartile range was varied, and some had been living with these symptoms for up to 28 years. And I think that reflects, what really I'm very passionate about with people with enduring psychotic illness is the onset age. Onset age is usually quite young, and these are chronic illnesses of which it's important that people get a second review, or that the management plan does get revised or a refreshed look, because these are illnesses, as we know, stay with people longer term. This graph talks about functioning levels of the consumers when they were referred to TRSP. And the one that we, in terms of the HONOS, sorry, I've got a call coming through. In terms of the HONOS and the K10, they're not super specific for illnesses like schizophrenia, but they are things that we do collect for ministry. The ones that I wanted to focus on in this graph were more the green bars here. So in particular, the SOFAS, which is the Social and Occupational Functioning Scale. It's a very helpful indicator of disease severity. And as you can see, the average of the consumer when referred to us, their score was under 40, which indicates a very severe level of impairment. That scale is kind of reversed. 100 means superior functioning, and the lower you go, the lower the level of functioning. So I guess as not unexpected, but saddening, is that when people are referred to us, their functioning levels are very, very impaired. And I guess that's one of the aims of TRSP, is to try to help those levels of functioning, improve quality of life for our consumers. So I wanted to move on. So that was just giving a bit of a snapshot of who's been referred and those characteristics and where those referrals have come from. But the next part of this slide deck, I wanted to talk about the achievements that have been, outcomes that have been achieved thus far in the last 4 years of the data that we've collected. And I'm very proud to report on this. Obviously, my time with the team is more recent, but obviously Julia's with the team that have achieved extremely profound, significant achievements. And so in particular, we collect data with the MRNs of our consumers after they leave TRSP and the service with us. We then track, within reason, what happens after. And this graph here displays the ED presentations of these consumers post TRSP involvement. And so on your left, I hope it's your left, you can see just in general ED presentations, and then on the right, when the ED presentation was specified as mental health. And in terms of the ED presentations, they reduced by 60%. The total raw figures were 145 presentations, and after TRSP to 87. And in terms of the mental health specific ED presentations, they dropped by 2/3. So from 68 to 23. And we can only make inferences from this. Obviously, we don't understand all the variables at play for each of those consumers, but an inference could be that there was greater stability for these consumers post the TRSP involvement, and obviously the support that they're getting from their local team. And likewise, the next slide, we also collect data on if a consumer after TRSP is admitted, in what unit setting are they admitted? And so here we're displaying acute units versus rehabilitation units, mental health rehabilitation units. And in the green, you can see the pre numbers, and in the orange, the post. And so similarly, we're quite buoyed by what looks like a shift for TRSP consumers from acute services to more recovery focused, hopefully more targeted care. And so this indicator is we're following the proportion of admitted bed days in a rehab mental health unit versus an acute inpatient unit. And over the course of TRSP in the last 4 years for the consumers seen by TRSP, this number, meaning the shift from acute unit inpatient beds to rehab, shifted from 15% to 50% post the TRSP involvement. So yeah, we're taking that as a shift and a marker of greater engagement and maybe accessibility, because often in the TRSP recommendations, there might be a recommendation for a rehabilitation unit and that those referrals are made and then accepted. And this is great because it's hopefully offering more nuanced, individualized care for that consumer versus just, I guess, unfortunately, acute inpatient setting care, you know, in a bit of a rebound setting, meaning, you know, admitted, discharged. And that's a different type of care than what the rehabs can offer. And then in terms of feedback, which, as Jackie mentioned, we'd love to hear your feedback in the comments or in the chat today. If you have any feedback, we collect feedback. We'd like to enhance this. It does rely on the referrer and the consumer responding to our feedback emails. But over the course of the last 4 years, this slide essentially displays how we collected it from the referrer. So using Likert scales to make it quite quick. And the key domains we asked about were, what was the referral process like from 0 to 10, 10 being, you know, a better, superior experience, as well as the communication with TRSP. And then we have offered in the past with our usual model of care, a case conference. And as you can see, when aggregated, the results sat around between 8 and 9. So we're very happy to hear those results, but you know, sometimes there's a bias in what we receive, that people who have positive feedback give that, and maybe less so than negative or average. So we'd really like to hear from everyone who uses the service, because it really can help us improve, and we want to improve it for both you and the consumers. And then likewise, we collect as much as we can from the consumers, if they're willing, their feedback. And so this pie graph just shows, we asked a question that's quite general, but just asked, did we meet their expectations? And what's positive, that 19%, you know, nearly 20% of consumers say that what they received was beyond their expectation. Obviously, we'd like to really increase that. But then the others, that 35%, said it was all expectations were met. So that's nice to hear. Obviously, there is the 8% that didn't want to say, and also the 38% there that some of the expectations met. And what we'd like, there is also a qualitative aspect to this as a free text response, of which sometimes it's not filled. But we'd love to, and if you could encourage the consumers to fill this out so that we can know what is working, what isn't for them, how can we improve things. And this is some, there was a lot of positive excerpts. There wasn't too many negative. Again, there could be bias in the response, a positive bias there. But these are some of the comments from the consumers, which are really encouraging for us. So a consumer being able to talk, getting some quality out of my life, being able to get things off my chest, talking about the future. Others saying, I felt listened to and it gave me something to think about. And then the third here is an example. It was very good. I'm so glad that your team was able to help. I've never done something like this before. So that's really positive to hear, and we hope that that continues. We also do want to hear, though, what isn't working well for consumers and referrers and make adjustments. So I'm just checking time. Yep. To be honest, that was the majority of the slide deck. The next, though, is about today and going forward. And for those who have referred to TRSP before, our previous model of care offered the whole assessment. So it was medical, allied health, trying to involve the carer as well as the consumer, giving feedback through a case conference and discussion with the team, then trying to give feedback to the consumer and or carer if they were willing to join us to close that loop, and then writing quite a lengthy report. And that was the service prior to now. But we've realised on reflection that there's other ways that we could offer help. And in some cases, actually the whole assessment isn't necessary, and maybe not what the referring team would like. So we have thought about other streams, we are calling them. And so there's 5 streams versus what we just had as 1. Stream 1 to 3 is the whole assessment, and it may include allied health, medical, or a mix of that. Stream 4 is for our rural regional partners who just need a neuropsychology assessment. It might be to help them get, the NDIS application over the line, something for guardianship, and our services out there, regional remote, don't have access to a neuropsychologist. And then stream 5 is what we're calling our 1-hour case consultation, which is we're trying to do it to keep a momentum, to get referrals completed quickly, particularly if a team has a relatively straightforward, quick question, could be about medication. And so we can offer that. It could be more complex, but we think that this is a good approach to try to offer you as the referrers some flexibility and be more individualized to what that patient might need. So this is just started, and we'd love to hear your feedback. We'll also be collecting and evaluating ourselves. But when you do refer, you can identify which stream you would like. Obviously, then we talk as a team, and it might be that maybe the whole assessment is better than the case consultation if it's quite complex, but we will work with you about what could be the best approach and navigate through that. I just will I've essentially said most of the things here of why we want to do this, but we want to really improve the service for you as the referrer and the consumer. But obviously the other larger goal here is that we would like to scale up. We'd like to, reach out and serve more people. And this model will probably allow us to do that with the resourcing we have. In terms of just seeing if there's anything else in this slide to the referral, which I can jump to here. So at the moment, the best way to refer to us, as you might know, was still through the Mindgardens website, but it was downloading or printing off a paper referral document, of which would have to be filled out by hand or typed on and then sent back to us. What we have developed is a digital form now, which will be used through the Breadcup portal, and of which there will be just a simple link of which you can click on, fill out digitally. This is just an example of a part of it. You can save it and come back to it if necessary, but essentially everything will be there. And you can also add attachments if relevant, like other reports, etc. And that will automatically come through to us, and you will receive notification, confirmation of us receiving that immediately. And then we will follow up with via email with you. So we're hoping this speeds up the process for you and also for us, and also improve the lines of communication. And on that note, if you're unsure about a referral, we're always very happy to receive emails and to discuss that. So the best email is listed here. I'm very happy to share this slide deck or email if you'd like to contact me, email you this if you can't write it down now. The best person who will respond to you usually is our wonderful operations manager, Suzanne Farage. And yeah, no question is a silly question. We're very happy to receive your emails, both about queries or feedback. So I wanted to just spend a bit of time on the future directions, of which, as I mentioned at the start, we do have plans already in place. So one of those is, as Jackie mentioned, part of TRSP is not only providing consumer clinical support, but it's also about trying to improve our clinicians in the state confidence and capability of serving those who have enduring psychotic illness and their carers. And what we'd like to do and offer is, in conjunction with the webinar series, which, as you may know if you've attended this prior, this is more higher level, it's essentially a didactic mode of webinar. But we'd like to go a bit deeper and provide something that's a little bit more interactive, a la kind of workshop. And we have been able to secure some funding to offer that next year. So we're calling it the Masterclass series. It will be, there'll be 4 in total, spanning from February to June. And 2 of those will be on what we're calling the foundations of practice, which will cover things like an understanding of enduring psychotic illness, general principles around etiology, pathophysiology, management, and is open to anyone. And one of the things that I've noticed in my journey so far is that often we don't get taught these things, surprisingly, in our structured curriculums, whether we come from medical, nursing, or allied health. So I think lots of people will get value out of this. And you don't need to be a newbie on the block. You could be, and if you've been a case manager for a long time, it could be helpful to refresh or be updated on some of the newer ways and understanding of psychotic illness. So that will be, we think that might be popular, so we're going to run that twice. And then the other 2 will be on comorbidity, so generally physical and nutritional. And the aim is that, and hopefully there'll be an ability for you to present cases or your own experiences with consumers anecdotally, and to work through what would you do in that scenario, whether it be right now or had it happened in the past, learning from that, and to give you like skills that you can then feel like you can then carry out the next day. And the other last one, which is still a work in progress, but we're thinking to talk about, I guess it's family systems, how we can support our carers better. So there'll be a theoretical basis to that, pulling on family systems theories, but then there'll also be the opportunity to talk about, obviously, your experiences with trying to care for a consumer and the carer. So we hope that will be of value as well. The places will be limited because we want to keep it, that interactional vibe. So we're thinking at this point about 24 people. So we encourage you to stay tuned and to register. So 24 people for each of the masterclasses that will be held. And the first will be conducted in February. The other thing that's on the radar and is definitely happening also from February is some visits to regional centres. And so we'll be in contact, probably through your clinical director. We'd like to come to an area where we can reach lots of people. So it might be one of the central areas of a regional LHD, but hopefully people from all kinds of community services and centres can come. And the idea is that we would like to provide some education, or we could talk about complex cases we'd also just like to see what your setup is and how we can understand that better. So when we do get referred consumers from your area, we are better nuanced at understanding what is available, and also try to support you with improving what is there available. So they will happen from February, and we'll be in touch, and we'll also try to get this out there through the Mindgardens Mind Labs email newsletter. Obviously, our collaborations with other partners, so PCLI and rehab psychiatry, that has already started, and that's an important collaboration. Obviously, they provide lots of support also for people with enduring psychotic illness. So we're trying to keep abreast of the movements and the developments in those spaces, and likewise, they also assisting us. The other two here are more, I guess, hopeful. So one is the concept of possibly adding an inpatient setting stream to the services that I discussed before. And I guess the advantage of this would be not necessarily the need for more intense observation, because we understand that you as the treating teams are already great at doing that and give us great communication information about that. But my thinking is, if it were to help involve other partners of which we have good relationships with, like neuropsychiatry, intellectual disability, other comorbidities that are a bit hard to work out in the setting that you might be in. So that is something that we are thinking through, as well as, and in partnership and kind of courting that concept, is the idea of partnering with industry researchers in this setting, which might allow us to be able to conduct more research more thoroughly, as well as maybe trial novel therapeutics. Part of the challenge, obviously, with people who have schizophrenia and trying to research and expand the options available and understand the illness more, is to have them part of research programs. And obviously, with the negative symptoms and the functional impacts they experience, it's very hard to get them to come to the research that is on offer. So this could be something that could assist with that, obviously with the consumer's consent and their support. So they are the future directions that I have listed. There are probably many others that you might want to add, or I'd love to hear from you for. I just wanted to leave it here with enough time to field questions, to take on your reflections of the TRSP so far, what you think has worked well, what hasn't, any questions about the new model of care, or anything else that could be related.
Great. Well, thank you so much, Brooke, for this wonderful presentation. It's been great to see the progress of the TRSP over these years, and I've certainly been fortunate enough to witness that over the entire history of it. And I think it's no small achievement to have been able to demonstrate that there is an impact of the TRSP in the first few years, and being able to convince government to actually fund the next 4 years, which is where we're up now, and then where you've come into. So I think that's really great to have heard the presentation of the direct impacts of what the service has done. So I mean, the fact that there's been 21% of Aboriginal and Torres Strait Islander peoples identified in the data is really quite something, and way above the population averages. And so you know that the priority population is being targeted, and also there's reduction in ED presentation of bed days. And I think the new model of care is really very interesting, and hopefully something that can challenge us to have a discussion. And the digital updated digital referral form is, I'm sure, going to make it smoother as well. So I'm going to just move into the chat box. Hopefully there's some not the chat box, people so don't forget to put in the Q&A section if you don't mind. And yes, okay. So I will. There is one question that's in the chat box, but just a reminder to everyone to put it in the Q&A for ease of us being able to look at them. There's a question from Jennifer about what's the capacity going to be like, and I think that's a reasonable question. Is the capacity going to change? What's been the averages per year, but also where do you think the new streams are going to take you? Is that okay if you answer that?
Yes.
Thanks.
Yes, I haven't included any waitlist kind of data because it was in the last year, you might be aware, if anyone who has referred, that we have had a lack of medical staff. And so the waitlist has been more than usual. Also, because the whole assessment process does usually take a long time. And so we found that consumers would be referred, but it might take, some months before the referral was complete, like the actual assessment and then report completed. But essentially, for the case consultations, we're aiming that they can be, if you refer, we can complete those within a couple of weeks, definitely within the month. And then obviously, and neuropsychology, our capacity is we have a neuropsychologist with us, both 2 part-timers, of which is a total of 4 days in the week. Our neuropsychologist is the one who is there, as well as Susanna, operations manager, the most days of the week. So our capacity for doing those neuropsychological assessments is good. And we envision that if you refer, particularly right now, we can complete those very quickly, most definitely within the month. And we will have our own benchmarks around this, but they are the aim so far. The whole of assessment does take longer, and it is a bit variable depending on the consumer's availability, where they might be. They might move services or settings, and we have to track that and locate them. And as well as if the care is involved, if allied health are involved. So that's a little bit harder to predict. But again, we hope that if you refer, we can do that within 6 weeks. That would be the ultimate standard. It's likely to be a bit longer with those other variables at play.
Thanks very much, Brooke. Just encouraging people to put some comments in the Q&A box if you're wanting to ask some more questions. And meanwhile, maybe I could just ask about the masterclasses. You're thinking you've got a couple of or several ideas that you've mentioned. Is there a way that people could input into what they think might be useful and helpful to them around this? Because it sounds like there's some distinct topics, but perhaps openness to suggestions. What would you recommend people do if they're interested?
If anyone has an idea so obviously the foundations, those 2 have been set, and the comorbidity, but the 4th one is still not completely set. So if there's anything that you think would be helpful, we'd love to hear from you. The best place to email would be either the email on the screen there or also my email address. But yes, it's still open for discussion. The 4th one hasn't been set down in stone. So yes, please send through.
No, that's fantastic. Thanks so much, Brooke. And from the US, we have Cindy Shannon Wycott asking a question. Welcome, Cindy. Hopefully it's not too late at night there. Do you get the sense that the consumers you see are interested in research, as there may be a perspective that they do not want to be studied, which is something we've heard before? So that's the first question, and maybe I'll just read the second part because they're both related. So are they interested in research? And then a related question, are they interested in novel interventions and or enrolling in clinical trials, or just doing better with what is already available? Do you think it's a good population to engage with in this regard?
Yes, I mean, it does depend on the consumer. Some of the consumers referred, and again, why we've offered the case consultation stream is some consumers don't consent to the assessment, but we can still assist the team by providing that kind of case conference setting. It is very variable, Cindy. But what I would say is for the consumers who do usually partake, my experience the last 4 months, they do find it helpful. They're often not sure what the referral means. And that is one other thing we're working on, is a consumer brochure, so that they're aware of what they're being referred for and the process of which they can receive at the time of the referral before discussing with the team. But I've been really encouraged by a lot of the consumers who would like to be involved in research or ask about what's on the horizon. So I think it's a cohort that's ripe for being asked about research and trying to get involved. The challenge will be that they obviously are around the state. So getting them to those research centres, and hence why I think that inpatient stream could be a really helpful added resource and service.
That's great. Thanks, Brooke. And perhaps that leads us to just talking about how the TRSP is a central piece of the broader ambition of a Mindgardens Psychosis Centre for Research and Innovation. So because of the success of the TRSP and also some other programs that we've been able to run, such as a Keeping the Body and Mind program, there's a whole lot of interventions, assessments and access to research that's really not available to people experiencing psychosis across the state, even though we know as it's the most disabling of the mental health issues that can arise in our public mental health services. The majority of people who are in inpatients or case managed in the community have got a serious mental illness, usually with a psychosis component. So we're really looking to this next phase of embedding research and clinical together. So in the absence of anyone else asking a question, Brooke, in relation to...
I must have been so clear then in my presentation, there was no questions.
I was going to just ask you, because it's leading on from what Cindy's asking, I mean, how, and thinking about your broader work in internationally and other places too, how important is research and clinical in improving outcomes and care? And what's your overall thoughts around that space and what we could be doing more of?
Oh, it's integral, but I think it's about the setting and who's involved and the translational aspect, obviously, of it. And I think if we can create more of a forum with consumers and their carers about, what are the things that they grapple with, not just if we're talking pharmacology, but other things. I find and have done lots of forums with consumers and carers, both for New South Wales Health, but with the WHO. And I'm always amazed at the brilliant ideas that the people with the lived experience have. That often us as the clinicians, we're not in touch with. We can't be if we're not living it day to day. We can only surmise. So I guess that should be something of the future direction, is trying to, I know that there's great work already, but try to expand our lived experience, especially people with, enduring psychotic illness, to try to understand that a bit better so that we can then put resources in the right places for that right research. I think it has to be led by the consumer personally. The ideas about that, some of them, maybe the pharmacology less so, they won't be as aware of how, the biological aspects, maybe neurotransmitter wise, etc. But a lot of the other things can be informed by the consumer and the carers. I guess having clinicians involved in the research too, clinicians who both work on the front line and also involved in research, I think is very important. And it's one thing in psychiatry, mental health in general, that is we are less better at than the other areas of medicine and healthcare. So trying to build those synergies I think they're the way forward.
Great. Thanks, Brooke. And whilst you've been talking, there's been a few more questions in the Q&A box. I'll pose them to you. And Stedman has asked, if a consumer has been discharged from a community health, a mental health team to a GP, would or could the GP refer to TRSP? I know that's been a question.
That's such a good, it's a very good question. And I didn't put up like the dry aspects of, I guess, selection criteria. It is on the referral form and the other areas you can find info about TRSP. But unfortunately, the patient does have to be held by a community or inpatient mental health service. That is what the funding is for a hospital kind of New South Wales Health funded system versus GP, which is, it's annoying that it's kind of drafted out like this, but versus Medicare. So they do have to be part of the community health team or the inpatient team. And the other thing, just aside to that, is obviously we've had a few referrals through the private setting as well. And again, we can't offer the service to those consumers. It is only in the New South Wales health kind of system.
Thanks, Brooke. Next question was from Alana Scully from our own SES-led team. Great to hear
Hi,
about
Alana.
the service in more detail. Thank you. Regarding the possibility of the inpatient unit, might there be the capacity to begin to implement some of the recommendations that come out of a comprehensive assessment in collaboration with the consumer's usual treating team? There can often be challenges in implementing all that could be beneficial to consumers due to the complexities you've highlighted. I wonder if this could be a chance to build some positive momentum.
Yes, I think so. I mean, we don't want to take over from the great job that the home-based clinicians do, but sometimes, as you know, and as I pointed out, the chronicity, the length and duration of illness, and sometimes it is really great to get a new set of eyes, a refreshed team who, with the clear expectations for the consumer, let's get together to do this, and then let's see how that goes, and then let's follow up and support you with your home-based team after that. So yeah, I think that's the kind of the idea that we have in mind.
No, thank you very much. And another comment from Cindy, and this is again in relation to research, but directly linked to consumers. I think there may be a chance to talk about the benefits of research too, sort of an educational flyer on what research has already done and what we hope to do to help provide another perspective. And I think that's really important, isn't it, Brooke, that you actually think about other areas of health, such as cancer care. It's actually the bringing together of the clinicians and the researchers and with consumers at the centre, actually that's led to changes and improvements. So that's what we're really aiming for here too.
I think so. If we could model on that.
Yeah, and not discriminating against people with mental illness to not participate in research, which is offered to everyone else in other areas of health. I think there's been a sort of potentially overprotection of people for potentially good reason too, but I think working with consumers and families and carers to find out what would be of interest in terms of helping to improve people's lives. So I do think that's really important.
I'll just add on that, Jackie. I'd encourage Cindy and any of the other researchers who are with us today, please email us. We are very happy to try to, and ideally if it's a pamphlet, or to share that with the people that come through the TRSP process to see if they're interested and can be involved.
That sounds great. And just on that note, we've got a few things coming up in psychosis-related activities, and one is a psychosis seminar forum that we're hosting that's really about bringing this psychosis centre to life. So that's going to be later in this year, and next year is going to be a really big focus on trying to develop the translational research and clinical space on this topic. So I do want to thank everyone who attended today. It's a bit sad, but we need to draw the webinar to a close shortly. There's a few more little things to mention before we finish. So we did have almost 100 people online and more registered who maybe will look at it later. So that's great. And thanks very much. And a round of virtual applause for our speaker, and TRSP Clinical Director, Associate Professor Brooke Short. So thank you so much, Brooke, for that. We've got the future webinars and the QR code up there to note. Also just that we're going to be kicking off our 2026 presentations by Dr. Sean Halstead in February. And Sean's done a major piece of work along with his team in Queensland around the medication treatment of the big Lancet Commission paper that was published recently, a huge report on a way of thinking through medication treatments. So looking forward to that, but mostly thank you to all of you for taking the time today to attend this webinar, to care about people across New South Wales who are living with mental health issues and wanting to do better for our treatments. Thank you so much, and thanks to Brooke.
Thanks, Jackie.
Bye, everyone.